Anyone recognizes this song? Band, anyone? Who said that? Thank you. Song? Communication Breakdown. Good Times, Bad Times, 1969 album. It was originally called Too Good. The reason why it was called Too Good, this was Jimmy Page's first riff that he wrote as Led Zeppelin. And he wrote it in a very small room with a very small amp box, and he just thought it was too good. That's what he named it originally. He and Robert Plant, it was the very first song that they actually worked on together and wrote together. More importantly, it's and one of the few times Page actually sang his backup, which is a big deal. Love Led Zeppelin, love this song, but the topic we're on today is exactly, not just that it's too good, but it's communication breakdown. So my talk that I gave today was down in Spanish Fork, and it was about, they had a grand rounds on safety, and so I had to talk about safety in the OR and communication. When they asked me to do it, I had already said I'd do my talk today here, and I asked them if I could do it on Zoom, and they said that's fine. But communication breakdown, apparently I had to be there in person. So it happens a lot. So as we start talking today, I just want to ask that question. How does communication breakdown affect you guys in your own practices? What are some examples that you guys have that you deal with on a routinely basis for a communication breakdown that maybe slows down your practice, slows down your efforts in business and taking care of people? What are some things you see, Lindsay?
So I think in our clinic, with requirements regarding insurance and surgeries, a lot of times I'll be like, I did this, when they actually haven't, or maybe we have a hard time getting the information from someone else to get it approved for surgery. So
how do you work around that? What are some efforts
we've tried to just really make sure when we have a visit with our patients that we are asking specific questions, really like direct. When did you do this? Who did you do it with? How many times? So we don't have that later delay.
So through your experience, have you created kind of a template or checklist of things that you do in order to make those occur?
Yeah, we're always adjusting it because with insurances, things seem to keep adjusting, but we do our best to keep up on it.
So I just read of a post my buddy in Australia gave of a patient who is on insurance, came in with synovial chondromatosis, which means basically little pieces of rice inside their knee joint. So imagine walking with rice inside your knee joint. And they approved it, MRI, that was the case, the diagnosis, and the insurance company wrote back and said, oh, I'm sorry, your insurance doesn't cover surgery. So how that guy got away with selling that policy, I'm confused at. But the communication there is that, hey, you have insurance, oh, but small little detail, doesn't cover surgery, sorry. So this person has to wait 12 months to get a re-up on insurance, right? So communication, very key. Other examples? Good.
What you say is not always what the patient hears.
Yep.
I think a way, like something that I've done as a provider is trying to do the teach back method with them, making sure that we close the loop on any of those questions and trying to have them teach me after I teach them, just so that we're all on the same page. I also like to create goals with the patients so that we're all on the same page as we leave that assessment or that talking point.
So what makes you practice that way? What makes you, because obviously that's not taught as well and performed by everybody, otherwise we'd all be doing it. How did you change how you practice to that?
Experience, I worked on a neuro floor for 10 years, and neuro patients aren't the most consistent on understanding what you're telling them all the time because of diseases or injuries or whatever. And also in home health, that was something that I tried to focus on because those patients, I'm their medical contact in that home, and they oftentimes couldn't get out and ask someone else. And so making sure that every time that I visited, we were all on the same page and that we knew what was going on, has just spilled over as a provider now. So
Yeah.
to do that.
It seems like you recognize that you were potentially their only source of information, and that made it that much more important, right?
Yeah.
I love that. We should be doing that for each interaction we have. So, what have you noticed in your practice that makes the communication get worse, or that allows that communication breakdown? So, not fulfilling requirements of insurance, and that's something you notice, and we can adjust from it. But other things that maybe get in the way of effective communication, or that causes the patients not to hear, right? 27% of what we say in the doctor's office is what patients respond to being able to report back. So it means there's a huge amount of information we're not giving them.
Sometimes time between interactions on providers really gives them an opportunity to muddle that information and pull one thing, and then when they do a research class with Dr. Google, and then they come in and they're like, yeah, my hand really hurts. I'm just like, it's weird because I have cervical radiculopathy here. I think we're supposed to treat your neck. But they've told the front office it's a hand injury, and they've set them up with the DASH form, and like, you come in and you're like, okay, well, this is probably what we need to do, and then then you're educating again.
Mm-hmm. I saw something online where someone said they went into a doctor's office and said, hey, I know what my diagnosis is from Dr. Google. I'm just here for a second opinion. It's kind of scary, but it's also real, right? So I think recognizing what causes our breakdown, so recognizing that patients are coming in armed with good and bad information, right, will help us with communication breakdown. Recognizing that a lot of them forget, so we need to have them repeat back. Anything else? I saw you raise your hand.
To me, it goes back to teaching young kids in that telephone aspect, where it gets passed all the way through, it gradually changes over time.
Mm-hmm.
And then the other thought of that is just making sure that we take a complex subject and make it simple, and try to make something, whatever it is that the patient is kind of referring to, trying to dumb that down as best we can, so that my 6-year-old could understand portions of it. And if he could understand portions of it and be able to bring it back, then we know it's somewhat of it staying in there a little bit more.
The Michael Scott idea, right? Teach it to me as if I'm 4, right? Good. Raise your hand.
I was going to say, sometimes I notice I give my patients a lot of information in a small amount of time.
Yep.
And so maybe prioritizing one thing at the end of my appointment to really make sure they understand. Even though I know there's a lot of things going on, it's probably not helpful for them to hear all these different things, because then they're not going to remember anything correctly. And so maybe just focusing on one thing in my appointment to really make sure that they understand it.
I think I love that you're simplifying your message, right? Which is going to help that communication coming this way, right? We can't always affect the communication coming towards us, but definitely the communication coming out and making it salvageable. So the question I want you to think about as we go through this little talk or whatever we discuss is how can we help avoid communication breakdown in our practice and our communication with each other as we work together in this group. This is Dr. Nick from Simpsons singing the leg bones connected to the hip bone, the red things connected to my wristwatch. That is just a simple example of what we're going to talk about today, something that we do in the OR. And I want to talk about the elements of timeout and how this is beneficial. Now, I'm not going to go over timeout and why we do it and all the little details and boring aspects of it, or else this is going to happen to you. The elements of timeout, I just want to go over real quickly. So basically, before we do a procedure, the first thing we have to do is we have to make the room quiet, which is hard because the music's rocking. Carolyn's got Dr. Dre on loud. I know it is, I love it. You gotta pause it, and you gotta listen, and everyone has to be involved. So the first thing that happens is we've gotta say, all right, time out, everything stops. It's almost like Wayne's World, right? Car, game on afterwards. Room gets quiet, and then the surgeon reads aloud the patient's name, goes over the consent form, and then the anesthesiologist is going over the wristband. The nurse is reviewing the consent as they read it. Surgeon reads the name, the date of birth, the procedure that is consented for. Not the procedure they're going to perform, but the procedure that they had consented for, which is very, very important. The nurse verifies the anesthesiologist verifies it as well. And then we point to the site we're operating. it's the appendix, someone's got a finger on the appendix and it should be a marking there. For the knee, I find my marking on the leg, I point to the knee and I have my fingers on it. Almost ridiculous, elementary school level of pointing things out. We then go over the allergies to make sure that no medications are given incorrectly. We then go over antibiotic type and preoperative antibiotic dosing to make sure that we did it correctly and it's appropriate for the patient's size and it's appropriate for what we're doing in that case. In the case of an infected joint, there's no antibiotics. Hold it until the cultures are obtained and then we'll give it. And then there's another timeout basically when it's time to give the antibiotic, like, hey, let's give that now. We're verifying that we did these specimens, so let's give the antibiotic now. And then after that, we make sure that whatever we're doing, there's imaging that's appropriate that can further verify it. So if it's a API, there's a MRI or a CT or ultrasound that's up to confirm that, hey, we're removing the API and that is in this patient, so I didn't look at someone else's ultrasound before I'm going to take out this person's appendix. Or more importantly for me, for my cases, if it's a fracture, I'm visualizing on x-ray, see, that's this patient, that's the fracture, that's the right arm, it's correct. Verifying, again, at an elementary school, as if you're 4, confirming that you're in the right location. We then we make sure that the implants or the equipment is correct. So, all right, we're doing a total knee. Do we have all the instrumentation? Yes, we have everything for the robot. In case the robot goes down, do we have backup instrumentation to do a manual? Yes, we do. Okay, for me, I know I'm doing a size 3 femur over size 3 tibia. Do we have those implants here? Oh, I have this. I don't have a backup for that. Okay. Get them here now. I'm not going to start until that's ready, right? Because what we're trying to do is just make sure that we've got everything in the kitchen sink on backup. Because the last thing you want to do is show up to the OR and have your pants, be caught with your pants down, right? And then we go over Sharp's plan, making sure we don't hurt anybody, that we have a plan for where everything should be maintained. We have a place where we can put the Sharps after we use them. And then we talk about fire safety, and if you're Gary Edwards, you talk about where the nearest fire extinguisher is. That's not on timeout, that's just Gary's going above and beyond, as he usually does. So, now that you're tired and asleep, why do we do this in orthopedics? So the timeout is, most people don't think about it, they just kind of gloss over it and we do it, but this is lots of data to show the benefits of doing timeouts. Again, this is probably the driest topic to talk about here at Rounds. This is what I talked about this morning at Spanish Fork, but as I prepared for that talk, it got me thinking really about communication and what we can learn from it. One of the reasons we do it is because we're asked to. And so as you think about things in your profession, in your spheres that you're doing, what things are you doing that you're doing simply because you're asked to, and have you forgotten the reason, right? For me, why do we do a timeout? Because I want to make sure I'm not doing the wrong surgery on the wrong patient at the wrong time, with the wrong indications, with the wrong materials, etc., right? This is all about the patient. Now, as we think about timeouts, we want to, again, fall asleep again. But it's really going back to the reason why we do it is because it's going to be helping the patient. We're enhancing communication, enhancing their safety, reducing wrong side surgeries, which has been proven since the 90s, that we've had a significant reduction in wrong side surgeries and wrong procedure. And we're enhancing OR efficiency, which is really what we've seen in the past decade or to two decades, is really timeouts just enhancing the efficiency. Because as a surgeon, as we step up to the operating table, there's so much going on in my mind, right? It's, hey, did everyone follow sterile protocols? I'm watching like a hawk. Hey, change your gloves, please. I saw you touch that. I don't like that. Should we do a Salvastus approach on this knee? God, I don't know. Is this really? Obviously, Nathan's going, yes. Why would you do anything else? Yeah, this patient I think would benefit from let's do Salvastus, but I really don't like your bone quality. Maybe I shouldn't press fit. Maybe I should be cementing on this patient. MRIs aren't great. She's got osteoporosis. Hope they do their PT. I hope that the home health contacts them because they haven't heard from him yet. And what would Carolyn do in this situation? I don't even. I think she would do that, but what Gary, what Jordans was he wearing today? Were those blue ones? Squirrel. Oh, okay, over there. The point is there's so much going on that we have to take that time out for us to stop and go, okay, all of our distractions out of the way. Let's focus on what we're here for. We're all working together to create the same outcome on the patient and everything is right. The situation's correct, right? Most importantly, what would Carolyn do? So elements of the timeout that are important is the first thing I love is that everyone has to pause. So I hate that you have to stop the music. But you have to pause and step back and go, okay, why are we doing this timeout? Why are we doing this surgery? Maybe we should even take a step back from timeout and go, okay, why are we here today on this patient? Because they're miserable. They've got a knee that's not working. They're just, life sucks for them. And recognizing that, yes, we do so many of these that it just looks like a knee that's prepped and draped and I just step up to it and I do my thing. But really stepping back and recognizing the trust that they put in us, the ability for us to be able to help and make a difference, and then making sure we're all on the same page. So pausing, making sure we're all involved. And along with that is making sure the environment is quiet, that anyone has the chance to speak up. And that's the point, is if someone disagrees, they go, no, patient's allergic to ANSEF, we're gonna do clindamycin. Okay, thank you, good catch. Is that correct? Yep, anesthesia verifies that's correct. Okay, great. Continue on the timeout, right? So stop, hammer time. Or another way, stop, hammer time. So after you pause, you verify. The other elements that I want to point out is verifying imaging, so confirming what we're doing. And again, confirming why we're doing it and making sure that it's the right patient. And the third element that I love about it is verifying implants and equipment available, being prepared in every situation. So one of the examples I had is I had a hand case I was doing, and the plan was to do a pinning, and they didn't have plates there yet. And he said, oh no, it's a clavicle, I apologize, it's a clavicle. They didn't have the plates there yet, but they did have the ones you could remove. It was the implants from a box. So basically you do that and then you could use these other screws. And then it'll be 30 minutes before we're there, just go ahead and get started, we'll be there in 30 minutes. And just in case you've got this box of a plate. And the plate that they had was not the plate that we ended up using. And so we waited 30 minutes, which is not a big deal. It is in your OR day because you're like, oh my gosh, I just want to get home, I want to get taken care of other things that I've got to do. But had we just gone ahead, we would have had the patient open and waiting for the implants to be there. Which again, I think in the grand scheme of things, maybe that wouldn't have mattered too much, but being prepared is key. So a lot of people will say, oh, the timeout just takes too long, or it's just a waste of time. But realistically, it doesn't take too long. This is the example of a timeout that we do. So I'll just do it real fast. Patient's Jane Doe, date of birth is 1-2-3-4. She's consented for a right total knee arthroplasty with robotic assistance. She's allergic to penicillin, but test dose was given and she did tolerate it. Anesthesia, is that correct? Yes, it is. The right leg is marked, visualized, surgical field. I'm touching it. The imaging CT scan agrees it is Jane Doe. We're doing a right knee. She's had 2 grams of NSEF, 1 gram TXA. We're planning to cement a 3/3 femur over tibia. However, we're going to go one size up, one size down available in case we change our minds. On each of those, is that correct? We have that? Yep, the reps confirm that they're in the room. Great, her blood pressure is 94/40, so we'll do a tourniquet at 250 after we exsanguinate. Sharps are protected, there's a neutral zone established, so anytime we have a sharp, we'll place it here. There's a fire risk of 2. The nearest fire extinguisher is outside of OR2. Does everyone agree? Yes, everyone agrees. Does anyone have any questions or concerns before we start? Yes. The next room, the patient's not here yet. Oh, don't matter, I don't want to hear about that. Any issues with this patient? Nope, we're good. Okay, let's start. That takes 30 seconds, right? So even though it seems like a checklist, seems like a boring, dry thing to do, there's so many elements in that are key to patient success and outcome right there, right? So this is very interesting. So they did this study where these pediatric cases, they did 1,400 cases, but they told this facility, they said, hey, in these next cases, we're gonna randomly check your timeouts and see how they're doing. And so what they didn't tell all the staff that were involved at this hospital was the surgeon's randomly going to leave an element out or do something incorrect during the timeout. We want to see if anyone will catch it. Now they didn't tell anybody, so the only person that knew obviously was the surgeon. And so they would intentionally, for 120 cases, intentionally do something incorrect during their timeout, just to see if anyone else would catch it besides the surgeon. Now the surgeon should be the one catching it, and obviously he knew, so whenever they would say it, so like, hey, we're doing the right arm, then they'd continue, and obviously they're doing the left arm, the surgeon would be like, okay, actually no, sorry, that's the left arm. And then they would mark down that nobody caught it. 56% of the time, they caught the mistake. On something that's routinely done every day in the OR, it is key. Everyone knows it, like, oh, the timeout's so boring and stupid. 56% of the time it was caught, which means the rest of the time was not. Of those who caught it was the anesthesiologist, because they have nothing better to do than to listen. Yeah, except for control the music, but usually it's our nurse because we don't trust their taste anymore. Residents, only 6%, which means that there's a fear to speak up to their attendings, and even more so as a student. 1% of students, which means that that student probably didn't get in because he spoke up, right? That's a joke, but there's also some fear, right? Because if the student doesn't want to be wrong, but realistically, what's the focus? What's the point of the timeout and why we're doing it? Another way to say stop hammer time is cease all activities thou art engaged in, the hour of the hammer is upon us. Okay, so great, surgery goes amazing. We clap hands, we spike footballs, we're excited about how it goes. Communication over, we did our job, right? So in the OR, we also have something called a debrief, which sadly enough is rarely performed, though it's supposed to be performed on every procedure. As the surgeon's scrubbing out, we're supposed to do this. We're supposed to verify what procedure was done, which is very important because when you go in, for example, for like a shoulder scope, you're like, all right, hey, we're gonna do a shoulder scope with subacromial decompression. And then you actually find a rotator cuff tear, and you find a labral tear, and you find all of this stuff that was not expected, but you caught it and you're there, and the patient said, yes, anything that you've got to take care of in that shoulder, I want you to take care of, you have my permission. Verifying that that's actually what was done. Identifying all the needles, making sure we didn't leave anything in there, like a wristwatch or a junior mint or anything else that shouldn't be left in a patient. Specifying any cultures that you obtained, any packing that you left or had to remove. The wound classification so that we know exactly antibiotic treatment and how we should be treating it. Instrumentation and what implants we left in. Believe it or not, that's not as accurate as that should be. As a surgeon, when I look at doing a revision knee or hips, I go back and find out, and all they said was, we did a DePuy knee. Great, that doesn't tell me anything. I need to know sizes, I need to know style, I need to know exactly what I need to do. Looking at the total EBL, the IV in, the urine output, and then again, one other thing that's very rarely discussed is key concerns for the recovery. Hey, this patient, I think, has a history of AFib. They're on Eliquis. They'll be starting it right away. They may have some bleeding, so making sure we communicate with the home health team that, hey, this may be one that we need to change the dressing on often. Again, another example of communication, but realistically, that debrief this is what that debrief is, and we skip over it, but look at the different communication tree and how important it is coming from the surgical team communication to all the different people and instances of where that communication of what was done is highly important. And had it been done correctly and specified and made sure it was good, you're covering all of this. So the example of a debrief is very simple with that previous case. We did a right total knee arthroplasty with MAKE robotic assistance with cemented 3 CR femur, 3 universal base of tibia, 9mm CS poly, 32mm asymmetric patella. We used all of our surgical injection. We irrigated the knee out with Aricept and then normal saline. 2 checkpoints that were in were pulled out. The 4 pins that were in were pulled out. ANSEF was given 1 TXA at the beginning, 1 TXA at the end. Oh, no, doc, actually, we didn't give that second TXA yet. Perfect. Please give that. Okay, great. EBL was 100, tourniquet time was 47 minutes. Counts are correct. Correct, yes. And then also for an improvement, that 3 poly, I was pulling it and I broke it. So can you please tag that and let's get a new one for the next time we have to use this pan. Yep, that sounds perfect. Again, another 30 seconds. It's not difficult, but there's so much information there that is key. There's frequently times where I'll say, hey, we use a 32 May symmetric patella, and I get to hear, no, we actually use a 35. Oh, that's right, I remember we changed. I thought it was 32, right? And so that helps me on my dictation remember that I use the right implant. So in summary of the debrief and the timeout, it's communication. It's simply just talking with each other and communicating with what was done with the patient, right? So the summary with which I like why I really liked giving that talk earlier at Spanish Fort today was really emphasizing to the teams that was there that we can use the timeout not just as a checklist, but actually in all of our aspects of our communication, right? Do you have something like a timeout in your practice when you're handing off information from one provider to the next? As you communicate as physical therapists to your surgeon, as you communicate as pain doctors to the physical therapists of what they need to be doing, are we doing that in our post-operative care? Hey, this was an anterior approach for home health. Can you make sure they're not extending the leg? And what are we doing that we could be improving upon with our communication? The timeout, again, is one of the most boring discussions overall, but it's so critical. And I think we overlook the communication that is broken down when we don't follow it. The other thing I love about it is we can verify what was done, and if everyone agreed upon it and understood it. But more importantly, that we have the ability to disagree. Hey, no, that's not what was done, or hey, this was a concern I had. At the end of every case, I usually will ask, hey, anything we can do better next time? And I want someone to say, yes, next time, can you get here earlier, Dr. Pitts? Okay, yeah, that's fine. Anything about this case? Yes. Can we probably need another assistant next time for something like this so it can be a little bit quicker. And again, I think a lot of times as I talked this morning, the people in Spanish Fork they said, yeah, we just don't feel comfortable speaking up. And how important and how terrible to hear as a surgeon that they don't feel comfortable to speak up when it's all about the patient care and the outcome. So hopefully this has been helpful to kind of think about how we do a timeout in surgery. Maybe there's elements in your practice that you can kind of think about some of those key principles. And again, of course, last of all, listen to more Led Zeppelin. Good. Any questions, thoughts?
So as someone who's not in the OR a lot, how often does a timeout catch something? I mean, is this? I know it's the culmination of lots of people, even before you get in that room, that have tried to make sure everything's set up right. But I'm just curious, how often is it that you find something that comes up? Is it common? Is it less common?
I think if the system is working right, it shouldn't be very common. I would say in our instance, it's not common to catch something, and maybe it's not that we're trying to catch something, it's just we're trying to verify that up to this point everything's been correct. I don't know, Carolyn, your experience, have you seen much that we've caught that was incorrect, that a timeout stopped? I would argue the same thing for airlines with their pre-checklist, right? How often do they catch a problem? Not super often because of all the things that they have in place, but when they do catch it, right, it's critical, it's key.
As a patient, I'm really glad you're doing this, right?
Yeah.
But I was just curious.
Yeah.
It's funny though, there are times where we'll be doing a fracture, it's very obvious this is the broken bone, right? And Gary's like, where's my mark? Where's my mark? Right? Like it's so, because you're so, I think that process means so much, so you feel very confident you will not miss something and do something on the wrong patient. So I agree, it doesn't happen much, but you never want to be that. It's called a never event, right?
Yep.
You never want that to happen.
Yeah, and so before that, even before the timeout, like you said, that process, I'll walk into the patient's room and go, okay, we ready? Yep, we are. Okay, what are we doing for you today? And they look at me like I'm an idiot. Like, yes, I know what you're doing. So I usually will say, stupid question, very silly, but I have to ask it. What are we doing for you today? Oh, you're replacing my right knee. Okay, great. And I make sure on my consent, I'm writing that I agree, it's on the board, the patient said it, and then afterwards I'll grab the marking pen, I'll go, again, silly question, which leg are we working at? And they look at me like, the left, and I'm like, this isn't a joke. Which one are we working on? The right side, okay. Correct side? Yes, then you mark it, right? And again, it seems silly, and they all laugh about like, well, but they always say the same thing, no, I'm grateful that it's that you're being this elementary, this 4-year-old style of communication, that you're just not looking, it's a never event, you're never looking for an incident because you're just verifying.
I think there's a lot to be said about specializing in different practices, because then you can do that one thing very well and perhaps better than everybody else. The disadvantage of specializing is that these things become routine. And there wasn't much said about what the nurse practitioner or the PA's role in these timeouts are. So I find myself a lot of the time during the timeout, oh, this is just a routine thing, and am I hearing everything that I normally hear? And it becomes, I find myself doing that sometimes in clinic too, when I'm verbally vomiting all over the patient about what arthritis is, and I've said this hundreds and hundreds and hundreds of times. It's not new for me, but it's new for the patient. And I think that's the important thing, that each one of these situations we have to recognize that even though it's routine for us, this is not a routine thing for this person. And if we treat it that way, whether it be in the OR or in a clinical situation, then I think you're less likely to have these kind of situations, and you'll be able to attend to the needs of the specific.
which is difficult in a day where we're now forced to see so many more patients and treat so much more often that we have to. I mean, efficiency is kind of our key thing. That's why I do enjoy the timeout, because it is a time for us to pause. Music turns off, everyone's quiet, everyone's paying attention, because at that point the most important thing that matters is the person on the table, right? In the OR. And that applies to you as the person on the table that you're doing therapy with, the person that you're adjusting their spine or going over their spine care or doing an injection on or anything like that, is being able to have something in your life that's a timeout and a debrief with each interaction that you have with a patient or with someone in your life. Even this applies at home as well. The ability to, at home for me, my timeout at home is, or my debrief rather, is dinner time. I get home, we have dinner, everything's off, we look at the kids, we ask their best thing of the day, worst thing of the day, what they're excited for, and of course we do our other family stuff after that. But finding those things in your life that's a timeout and a debrief, I think is going to be key to enhancing your communication, but more so even enhancing your satisfaction in your life. So great, thank you.